over here. 5 to 85. Yep, 5 to 85. What is your number one reason for abnormal results on a growth chart?
Misreading the chart.
Yeah, operator error, misreading the chart, something to do with that part of the chart. What is your daily dose of vitamin D that you recommend a baby is supplemented with? 400 what? What does IU mean? Perfect. Is mastitis a contraindication to breastfeeding?
No.
You guys are brilliant. Let's see, what level is pathologic jaundice in the first 24 hours? I heard you. Well, we're just saying numbers now. What if I said, what is your pathologic direct bilirubin? Remember that one? 2. That one's 2. So then what is your pathologic indirect at 24 hours? 8. Yep. Good job. An infant who is breastfeeding is still jaundiced at 2 weeks of life. Breastfeeding is going well. They've regained their birth weight. What is your most likely diagnosis? Milk jaundice. Correct. Breast milk jaundice. That's good. You guys are doing great. After today, we will be halfway through all of the material for your first exam. So we are just trucking. Okay, so we're still with the normal child. So the next couple of things we're going to really kind of dive into. What do you do with these normal kids? How do you separate normal from abnormal? Remember, pediatrics is really, and especially if you're doing outpatient pediatrics, primary care pediatrics, you're trying to look for you're normal, you're normal, you're normal, oh, you're not normal, and pick that out. So that's kind of where we're going today. So we're going to be talking about those developmental milestones. Remember, development is a little bit different than growth. So growth, again, is your actual body is getting bigger versus your development, your function is changing. So we're going to look at all of these specific domains. So when I talk about a domain of growth, you have 1 of 5. So if we're looking at our gross motor, those are large muscle movements. So is the baby sitting? Is the baby standing? Is the baby walking, running? These are your gross motor, large muscle group skills. Versus your fine motor is much more adaptive. Things like the pincer grasp, things like putting hands together, handwriting, all of your small muscle groups. Those are all the fine motor as a domain. Your personal social skills, that's going to be things like your joint attention. Can you recognize names? Can you do some of that personal social type skills that make you be able to function in society as you get older? Your language skills can be anything from making any kind of verbalizations to cooing to words to understanding language. There's both receptive language and then expressive language. So that domain is even further subcategorized. And then your problem solving skills. So how do they solve problems around them? And is that age appropriate? So we will dive into all of these specific milestones. So I know how much you guys love charts. I know you hate them, but some of this stuff is charts are really the only way that we're going to be able to do some of that. But I'm going to pick out the things that I really do need you guys to focus on. So for these charts, the goal, if you really think about it, the goal is to take a small little human who can just lay there like a little cockroach from their firstborn, and to get them from that to a functioning human that is upright and able to move themselves forward. So that is what we're looking at for a gross motor milestone. And then we need to take that same human who cannot have any kind of verbalizations other than to cry and scream and get them to a point where they can communicate their needs and wants and have that understood by another human. Okay, so those are those 2 domains really that I want you to focus on. So yes, fine motor is important. Yes, personal social is somewhat important. Those are a little bit more of the details. So for here, I need you to focus on the gross motor column and your language column. Those are the 2 columns that both for real life and for your pants are going to be the most applicable. They're the ones that are the most obvious and solid too when you're doing some of those. Okay, so those are the two that I need you to focus on. So let's start looking at this at the top. So the ones that are circled are also the ones that I need you to focus on a little bit more. So the ones circled in red, and then those two columns, gross motor and language. So if you're looking at the 2-month visit, they should start to have some head control and start to have a little bit of shoulder control. Remember, we're going from cockroach to all the way up. So the first thing we're going to try and we're working on is head and shoulders. Gross motor. At 4 months, the way to think about this is if they are on their tummy, that they are able to push themselves up, kind of like in a half push-up. So they are working on getting themselves upright. 6 months is going to be your anchor. That is the one that, when in doubt, I need you to know that you sit at 6. Sit at 6 months. Beyond that, you could figure out which direction am I in of 6 months. But sit at 6 is one I need you to anchor yourself on. 9 months, they are supposed to be able to pull to a stand or be able to crawl. So the way I think about 9 months, because not all babies are going to crawl. You have some that do like this weird army crawl and some that do this weird scoot thing. And I had one baby that just rolled their way there. And that's a combination of when you put your problem solving skills with your gross motor together. So really, the 9-month skill is, can you get your body moved somewhere? Can you get it to do that moving? So pulling to stand or crawling. 12 months, can you walk? And then can you bend down while you're walking? 15 months, again, is the walk backwards. And then 2, you can go up and down 2 levels, so stairs. So those are the ones that I need you to know for your gross motor. If you move over to language, at 2 months, there should be some sort of vocalization. So cooing, so this is between 2 and 3. 4 months, it should be some intentional laugh. So when they say laugh and a squeal, this should be intentional. This shouldn't be like, I just farted and now I'm making a noise, because that will happen before. This is an intentional, somebody is doing something and they are laughing in response to that. A 6 month, they should be babbling. So it's non-coherent, there's no actual words, but it is a intentional vocalization of babbling. 9 months is the big one. Pants loves this one. Where they say mom, mama, and dada, or some sort of repetitious consonant sound. So it could be baba, could be whatever, whichever one you want of that. But some sort of repetitious consonant sound, and then really nothing else. Versus 12 months, where it's mama, dada, plus 1 or 2 other words. So what the pants will try to confuse you on, I'm just telling you now, is between 9 months and 12 months. So make sure you can distinguish 9 months and 12 months on these charts. And then they just start adding words as they get older. Eventually 2 should be about half understandable and about 50% of words where they're putting 2 words together. So all the 2's go together. Another way to learn this, if you like it this way better, and if it just kind of catches your attention, is at 3 months they are cooing. Coo has 3 letters. 6 months is babble. Babble has 6 letters. 9 months they're starting to imitate that consonant sound. That has 9 letters. At 12 months they have 1 to 2 other words. So 12 months, 1 to 2. 2-word phrases at 2. 3-word phrases at 3. Full sentences at 4. So if that is helpful at all as a way to study that, just another option for you there. This is one area where I would say this will come as a shock to some parents. If you've never had a child before, or if you don't have another comparison, parents will often have no idea how much their kids should or shouldn't be speaking. And so there are some times where this, as a provider, just like if you were doing a physical exam and you were going and all of a sudden you saw someone's back and there was a giant growth, you would be responsible as a provider to say, were you aware that there is a growth on your back? Right? It's the same thing for kids with this. Some of your provider responsibility will be able to say, did you know that your child is not meeting the appropriate language developmental milestones? That is the physical exam finding that you are finding, and you're responsible then for telling them. So that can be a difficult conversation sometimes, but ones that make sure that you get them to the appropriate type of therapy. So one of those hard conversations that you might have to have. This is just another picture for those gross motor milestones, if it is a little bit easier to see as well. I usually put 4 months in there too with the shoulders. So shoulders like pushing up into baby yoga. So that's what it should be. These should be your red flags. Seriously, we don't pass go, we don't collect $200. So if you see any of these on exam questions, on PEDS questions, or in real life, these should be the ones that kind of stop you, okay? So what I will say as a general rule is that developmental milestones are one section that can really freak parents out, right? If at 6 months your child is supposed to be sitting, and you bring your 6-month-old in and they're not sitting, and you as the provider say, your child's supposed to be sitting, they're not sitting. That will really freak a parent out. So usually, just me as a provider, I will give children till the next visit to accomplish the last visit's task, because that still puts them in the 2 standard deviations of normal, right? So if you're supposed to sit at 6 months and you're not sitting at 6 months, okay, we'll work on some things to be able to sit. But if you're not sitting at 9 months, now you're outside completely the standard deviation of that. And that's when I really start to intervene. Okay, does that make sense in how we do that? So you get one more. So for gross motor, so one of the things that you worry about is, are you doing things too fast? So sometimes too fast is not appropriate. So if you had someone come in and say, my 1-month-old is rolling, isn't that great? As a provider, you should panic a little bit and think, oh my goodness, what kind of hypertonicity, cerebral palsy type concerns, neurologic concerns are going on in this child? So that would be an example of early. So if somebody is doing something way too early, there can be concerns on that side. Conversely, if something is happening way too late, they come in and they're 5 months old and they still can't get their head up, and you're thinking, well, that was supposed to happen at 2 months. Now it's not even happening at 5 months, big concern. Same thing, if they're not sitting at 7 months, you're worried about that core and that there's some kind of hypotonic condition going on. The other one that will get you sometimes is hand dominance. So you should see children that have no preference for hand. Up until about 18 months, they are using left hand, right hand interchangeably, so there's no way to be like, are they going to be left-handed, right-handed? If they're consistently using one hand and not using the other one, that's again another concern that something potentially neurologic could be going on. So early hand dominance, early rolling would be concerning signs of a developmental milestone too early, whereas not being able to sit, not being able to roll, not having head control would be red flags of something that's too late. Language is going to be similar. So if you failed a hearing screen before the age of, or any time actually, but if you didn't have anything definitively passing by the age of 3 months, that would be a concerning hearing screen. If you have no variation in that voice pitch by 4, so you're not starting to do any of those cooing or intentional sounds. Same for babbling. If you really have no words by 15 months, that would be really concerning. And you're not pointing by 18 months. So children will understand the gross and fine motor before language. So you should have these little toddlers who are just grunting and pointing at things before they're able to say, Mom, can you please help me get some orange juice? They're just going to point at the orange juice and grunt at you. Okay? Yes, sir.
Is there a separate system or separate scale for kids that are deaf, for example?
Yes. Yeah. So if there's a whole, all kinds of different things of what should kids be doing if they, let's say, Down syndrome, Turner syndrome, deaf, blind. There's a whole separate side of what to do with developmentally challenged children. So, or even children that have special circumstances like that. So we can talk about that if that's situations. Yeah. And then this was back to that speech. So if you have a child that is not half understandable by the age of 2, not 3/4 understandable by 3, and not fully understandable by 4, that would be a red flag. And so this is understandable to a stranger. I need you guys to circle that word stranger, right? Because you'll hear sometimes in an exam room, this child just says some sort of Martian language, and the mom is like, oh, they're saying they like yogurt. And you're like, what in the world? Like, you just in no way, shape, or form was that any of the words. So they need to be fully understood by a stranger by the age of 4. Otherwise, that is your responsibility as a provider to say something about that. Few other red flags and what to do about them. So you must act quickly on this because this is such a high period of development, right? This would be functionally in that first year of life like saying, hey, you didn't develop properly at IPAP. IPAP is this year-long crunch time that if not, you're going to get left behind, right? Similar to these kids. So you have to intervene very, very quickly. So if you are doing some of your evaluation and you notice that they're talking like they should be, so there's some sort of a speech delay, a language domain delay. Your first thing, obviously, you're going to look to say, is their mouth okay? Are their ears okay? Both for receptive and expressive speech. And then your first thing that you are going to do, the very first thing, is not a speech therapy referral. It's going to be an audiology referral. So audiology is first, because if you can't hear, you will never learn how to speak correctly, okay? So if you just put in a speech therapy referral with no audiology evaluation, that is incorrect. So audiology first, speech second. If you have your gross motor delays, so they're not sitting, they're not standing, they're not walking, gross motor delays, those go to physical therapy. Your fine motor delays, all of your little adaptive skills, those go to occupational therapy. So things like feeding issues, handwriting issues, some of their specific hand motions, all of those go to occupational therapy. And this will be one both for kids and adults that you will need to ask specifically. If you say, do you see any other doctors? People will be like, yeah, I don't see a cardiologist, so no. And then they'll call you, can I have a repeat referral to my speech therapist? And you're like, I asked you that, right? So you have to ask specifically, do you see any other specialists to include physical therapy, speech therapy, occupational therapy, play therapy, sound therapy, vision therapy, like there's a million types of therapies, okay? So those are the big 3, speech, occupational, and physical therapy. Which takes us into a little bit of a difference in surveillance and screening. There's going to be a lot of this that you are going to do, but pediatrics is a particular area of this. So surveillance is just what it says. You're surveilling all the time. So if you are going into a room, you are checking out the room and surveilling it. So every visit, every single patient that comes in, you're looking for trends with these patients. Think about vital signs. You're getting vital signs at every visit. You're surveilling those. Versus screening, that you're going to do a specific screening test, questionnaire, evaluation at a specific time where if you intervened right then, your outcome would change. So we're not going to just randomly, that's why we don't do pap smears on 10-year-olds. That's why we don't do mammograms on 20-year-olds, right? You do a screening when the specific intervention would change your outcome. So same for pediatrics here. Your screening also will not make your diagnosis. So you are going to screen, and then that gives you an indication that I need to do further things. So let's use your, newborn screen as an example. You get a newborn screen, the newborn screen says, oh, our thyroid is low. You do not call the family and say, you have hypothyroidism in your baby. That's an indication to get further TSH, free T4, T3, and evaluate further for hypothyroidism. Okay, so these screening things allow you to get further follow-up. Ones that we're going to talk about, some are labs, some are screening questions, some are questionnaires, some are testing in clinics. There's all kinds of different types that we will go through for this. A good example in pediatrics then with surveillance versus screening is the child that comes in at let's say they come in for a upper respiratory infection, come in for a runny nose or a cough. They're 9 months old, and you go into that room and they're still not sitting up, or whatever this says. I think that's what I put in there. That's an example of, okay, you're cold, let's talk about that, but also this is what's going on. So we need to address that because we are doing surveillance. Versus your standardized screening, who come in at a specific time. So we'll talk about these specific ASQs here in a little bit, but when they come in and they are 9 months, 18 months, and 24 months, you are going to do this regardless. Okay? Autism screening specifically happens at 18 and 24 as well. So if you want a long visit with pediatrics, go to the 18-month or the 24-month visits because those are just really long ones. You've got a 2-year-old wild banshee and like 17,000 pages of screening that you have to do, so buckle up. We'll get into those. So what does that look like then? I said we're going to do ASQs at 9, 18, and 24. What are ASQs? So ASQ stands for Ages and Stages Questionnaires. And these ones will go through all 5 domains. So when we started all those different domains, it's going to address every single one of those. And you can start at 1 month and go all the way through 5.5 years old. Pick a month, any month, they are out there. And the question becomes, well, why do we do them at these 9, 18, and 24 months? Anyone have any idea why we do them then? Some those are specific developmental milestones. Why else? Those aren't always vaccinations, but there's some there. This is when insurance has decided they will reimburse. So this is when the AAP put this out. So these are the only 3 that insurance on the outside will reimburse you for. The rest are because you're going to be a good provider to do it. So these are the ones that have become the standard of care. I would behoove you, if you have a concern at all for a child, that you pull out an ASQ, even if it is outside the 9, 18, and 24 month window. The other thing to use them, to know how to use them, is that you will account for any kind of prematurity more than 4 weeks. So if you're born at 40 weeks and they come in for a 2-month visit, you're good to go. If they were 39, 38, or 37 weeks, still good to go. Once they hit 36 weeks or below, they get that extra time. So if they come in at 2 months and they were born at 36 weeks, you're actually going to give them the 1-month ASQ. So if you had a child who, was born at 32 weeks and they are here for their 6-month well visit, which ASQ are you giving them?
5.
Which one? So they're 32 weeks premature. So yeah, that's 2 months, so 8 weeks. Now here for their 6-month well, which ASQ do you give them? Their 4-month ASQ. Yep. You account for that time. In reality, and I'll tell you, in reality, we don't do that. I would go ahead and give them the 6-month one, and then if they are failing that one, quote unquote, then I give them the 4-month one. Right? But if they're already meeting the 6-month stuff, press on. So, but that's how you would do that. You wouldn't necessarily say, oh, you're absolutely abnormal, you need to go all these therapies. They're still allowed to get that time to catch up. This is what they look like. So every different domain, you have an option. The parents can say, yes, they are doing this skill regularly. Sometimes they do this skill, and then because we're pediatrics and we don't like to say, no, they're not doing it, we say, not yet, we're not quite there yet, right? So your options then, if you are a yes, you get 10 points. If you are a sometimes, you get 5 points. And if you're a not yet, you get 0 points for each of your individual tasks. Now some of the tasks, and I will say these are a little bit older things, so sometimes we'll say, do you put a Cheerio in a plastic cup and use a string to get, there's some weird stuff that they put on there. Should these probably be updated to be like, can you call grandma on FaceTime by yourself? Yeah, probably. We're just not there yet. So a lot of times as a provider, they say not yet. One of the follow-up questions will be, have we tried it, right? So if it is, can you pinch a Cheerio out of a plastic cup? Well, maybe they can't do that, but can they click on a specific app on mom and dad's phone, right? What is the skill trying to show? So that could be a reason where they say not yet, as opposed to they truly can't do it yet. Yes, ma'am, what was your question?
Yes, ma'am. I'm really confused with the preterm and subtracting.
Yep. So if you are more than 4 weeks preterm, then you get those extra months to catch up. So if you were 36 weeks, you're 4 weeks premature. So whatever month chronologically you are, say you're 6 months, subtract 4 weeks. So you would get the 5-month ASQ.
Oh.
Like if you're, so if you're 8 weeks premature, subtract 8 weeks and give the closest ASQ to that. If you're 12 weeks premature, subtract 3 months and give that ASQ. Yeah. But if you're 37, 38, 39 weeks, you were just slightly chewy brownie. Came out just a little early. That makes sense? Cool. Okay, so once you take those totals then, the totals get added into this result grid, right? So let's say you went back here, this communication skills. So 5 of them said yes, 1 of them said sometimes. So each of the yeses got 10, that one sometimes got 5. So your total for communication was 55. You take that 55 and you put it down in that bottom area, that bottom grid. So it was 55, and you see that your options are, I can be in the white. White is where you're good to go. That is normal. That is the standard deviation of normal for that age. Gray is in the gray zone. You are outside the standard deviation, but you are not concerning yet, but you should do some sort of intervention. Black is in no way, shape, or form is this normal for this age. Okay, so black would tell you you need to do something today for that child. Gray says you need to either consider it, give them home exercises, give them some early intervention skills, follow them up sooner, and white says you're good to go in that domain. Okay, so that is how you're going to use those ages and stages questionnaires. So that would be one of those things that you're doing. So 9, 18, and 24 months are your ASQs, but anytime you're worried about developmental, you can also do those. Your other one for autism is just done at 18 and 24 months, and this is the MCHAT-R. So it stands for the Modified Checklist for Autism in Toddlers, and it's the revised one for a couple of reasons that we'll talk about. So it's a set of 20 different questions, with 3 of them being your red flag questions. So your red flag ones are going to be, number 1, do you think that your child is deaf? Not have you ever been told they're deaf or they failed a hearing screen, but have you ever been like, they can't hear me? And not the selective hearing, like clean your room hearing, but like they literally can't hear you. The second question is, do they make unusual finger movements? And so a lot of times people will say yes to this and they'll say, what are they doing? And the kid is just doing something funky with their hands that children do. What this is looking at is, are they doing some stereotypic self-soothing movement with their hands around their face? Is what they're actually looking for. And then upset by everyday noises. So I don't know really many children that love the sound of a vacuum cleaner, right? So this would be an example. Parents will say, yeah, they really hate the vacuum cleaner. Okay, but do they hate the vacuum cleaner like, oh, I don't like that, and move away from it? Or does that ruin your entire day? Right? So that would be an example of that. Hand dryers in a public restroom are another example. Is there some specific noises that literally ruin your whole day? So, if you have more than 2 of those red flags, or you have more than 3 of the total 20 questions, then that's when your screening should pop up to say, ooh, I think we need to do some further evaluation. So there's follow-up questions, there's all kinds of stuff beyond that. Failing the screening does not mean you have autism. Again, it's screening. It means you need to do more follow-up evaluation. Okay. Questions on some of those screening things before we start well child stuff? No, there'll be no questions. Okay, so what I want to do for well child is get you guys to understand what children are all about. So, well child exams can be tedious, it can be boring. The material can even be dry. What I need you guys to know is that children are very fun. Children are fun, and the more fun you are, the more fun the child will be. There will be very few times where if you just tell the child and you have a weird interaction with them that they're going to be fun, but if you play with them, they will be much more enjoyable, okay? So if you just spend the whole time playing with children, they will respond to you quite nicely. So when you go to your pediatrics rotation, the more you play, the more realistic the child is going to give you feedback, give you interaction, and then you will actually get a better exam than asking the parent, okay? So we are going to talk about some well child. Oh, it looks like I was flipping you off. I wonder if I can actually do this. Okay. We're gonna see how long we can do this for. Do we have a time hack for this? We have 5, so we have 15 minutes. So I'm gonna lecture for 15 minutes like this. Good. We'll see how it goes. Okay, so your standard intervals of when you need to act a fool are as follows. So you're gonna do your newborn follow-up at 3 to 5 days. So that is going to be, I'm checking on the weight, checking on breastfeeding, I'm checking on jaundice, bilirubin, those kind of things. At 2 weeks, what were they supposed to do by 2 weeks with their weight? Yep, we're gonna regain our birth weight. So that's what we're doing. That's why we really need that 2-week visit and to make sure the jaundice has cleared. Otherwise, we have what kind of jaundice? Breast milk jaundice, yep. Then we see them at 2 months, 4 months, 6 months, 9 months, 12 months. So really, you should be able to see your patients, your healthy patients, 7 times in a year. When's the last time any of you went to see your doc for a well visit 7 times a year? That's how often we are seeing these patients. And that's why your interactions with the families matter, because you see them really frequently. Okay? Then we see them 15, 18, and 24. So I'm not going to ask you specific months of this and that, but to the concept of knowing you see them a lot. So you should be able to pick out the things that are abnormal. What are you going to start seeing? So yes, you're going to do vitals at every visit. And remember, in pediatrics, your 5th vital sign is your growth charts. So you're going to be getting height or length if you are under 2, and weight, head circumference at every visit, and looking at those growth charts every single time. You're getting your vital signs, but wait, one of your vital signs that you're not going to get is a blood pressure until you're 3. Have you ever tried to get a blood pressure on an octopus? Which is what you're trying to do with a 2-year-old. It does not work. And again, the yield is not very high. So we start routine blood pressure checks at 2. Who would we get blood pressures on before then? Congenital heart defects, that's one of them. What else? I heard something else back there.
I said if you have a concern about any sort of heart or vascular
Yep.
issue.
Any congenital heart, so coarcts, anything like that. The other one would be if you have had a central line. So if you had an early central line, remember, you had one in your belly button. That's considered that central line. So if you were in the NICU and you had a central line, that would be an indication also. So things for hypotension, if you are in a systolic, remember it is a function of height. So your systolic doesn't have to go very high. So it's 270 plus your age times 2 would be your systolic. I'm not going to make you calculate those. Remember, I will give you your vitals, but you should know at least roughly what's normal, what's not normal. And then your diastolic should be 2/3 of that. And then everything is going to have a full head to toe exam from there. So what are your guidelines? So birth to 6 months, the babies don't care, right? They're like in cockroach mode, so they're just kind of laying there for the most part. Easily comforted by parents or provider, really any adult. And they're easily distracted. A light or like a pen, a toy, this goes a long way, right? So easily distracted. Very, very easy exam. So if you guys are like, I don't know about children, actually the babies are the easiest ones because they can't run away from you. They can't lie. Your hardest ones are going to be 6 months to 3 years old. Why? That age, they can run and they can bite. Right? Those 2 things make them some of the most challenging. And then once you get over 3, much less fearful of you, you can talk to them. There's a little bit of reasoning there. Sometimes it's like reasoning with very difficult country, but they are much more interactive. Your recommendations: to become smaller than the child. If you are talking over the child, no matter how goofy you look, that is still going to freak them out. Okay, so getting smaller than the child. Listen to the parents while looking at the child. Right? So definitely pay attention to the parent, but definitely the attention should be to the child. Let the child sit with the parent. I cannot tell you how many exams I have done where the entire exam is on the lap of mom or dad. That's so much easier than fighting the table. And then for the love of God, please do not wear a white coat on your pediatric rotation. You'd be much better suited to come in dressing like this. Do that. And then if you're trying to do ears or mouth, save that for last. Ears will make them bite you. Mouth will make them want to bite you. So what are we going to start? So these are the screening things for a child, for the healthy child. So meaning these are those things that we are going to do at specific intervals that are going to make a difference if we find something. So these are not your surveillance things, these are your specific screening ones. So we've already talked about some of these. These are a review. Newborn screening that we did at 24 hours of life, your congenital heart screening that we did at 24 hours of life, and that hearing evaluation. Ideally that's done at 24 hours of life, but must be completed by 3 months. Yep, we got the 3. Good job. And we're going to do vision at different intervals. We'll talk about an anemia check, lead check, tuberculosis check, obesity check, dyslipidemia, and STIs at different intervals as we go. Again, already got that for your newborns, so we'll skip down to infants and toddlers. We're first going to make sure that they have had that hearing and that their speech is appropriate for their age. Your vision, you can use the ocular screening tools down to 6 months of age. They're super cool. If you haven't used them before, it basically takes a picture of the outside of their cornea and gives you a number of how bad or good their refractive error or any kind of astigmatism is. So super helpful because the Snellen charts are a little bit harder with a child who's illiterate. So if you're like, which way does the E go? And they're like, I don't know what an E is, right? It's not super helpful. So yes, they can do boats and ups and downs and stuff, or we could just take a picture. So this has been a game changer for vision. And when we talk about eyes in that lecture, we'll talk about why. And then your anemia. So this one is one that I need you to star, highlight, underline, is the anemia check, which is blood. You are taking blood from this child, is going to be at 12 months. Okay, so this can, providers will debate. Do I want a full CBC? Right? Hematology, your last class would probably say, yes, you want a full CBC. Or do I just want the H&H? Which one is easier to get?
CBC?
No, but why? Where do you get just the H&H from in a kid? A heel stick. Yeah, you just prick the bottom of a heel. How do you get the full CBC? A full venipuncture, right? So if you just want the H&H, just get the heel stick. You want to know your diff, your platelets, other stuff, then you're going to have to get the full CBC. And I have debated over the years. For a while, I'm just getting H's, I'm just getting H&H. And then I flip back and I want CBCs for a little while, and then the lab can't get them, and I flip back. So I've gone back and forth. So there's no consensus provider-wise other than to do some sort of anemia check at 12 months. So up to you how you want to practice that. Your other screening tests. So lead is going to be both. So lead, you are going to do the lab draw at 6 months. So, or I'm sorry, at 12 months. So at 12 months, the same as your anemia screening, you will also need to have a blood sample of lead. The rest of the time, from 6 months to 6 years, those are with screening questions. Okay? So a big difference. Watch out for that because Pants and me love to do that. Right? Is it questions or is this a true blood draw? So the draw is at 12 months. The questions are 6 to 6 years. Yes, ma'am.
So since the anemia check is at 12 months and the lead check is at 12 months, then wouldn't it just make more sense to do the CBC? So you get a venipuncture for blood.
Correct. And that's where most people end up, except when they can't get the stick, and then they're like, what do you want us to do? And then we just end up with the H&H.
So then you just waive the lead screen.
Yeah, you waive it, or you just wait and you try it again at 15, 18, at 2. And as long as their questions are low yield and you document that, then it's best you can do. So, good question, really good question. And that is some of the reason why I started with CBCs and have gone back and forth. But yeah, really good question. Some schools will require this, so if they've never had it, you end up having to get it. Tuberculosis. Tuberculosis, you don't do any lab draws. This is questions only. So your questioning will start at 1 year of age, and you do not need to have any standard testing unless, or standard lab draws, unless they meet some sort of criteria. So your criteria is going to be some of the same things that you would think. Do they have risk factors, but then are they symptomatic? Are they increasing in how this is going. So, for example, healthcare workers. Does every child of yours need a TB screening test? No. But are you symptomatic? It prompts you as the provider to ask further questions. Make sense? So tuberculosis, just questions only for your screening. Dyslipidemia. This one is not questions only. Dyslipidemia is specific for a lab draw. So every single child between the ages of 9 and 11 should have one draw during that time. So if you get it at the 9-year well visit, you don't need it at the 10-year and the 11. If they say, no, I really don't want it this year, then you bring it up next year. So one screening lipid panel between 9 and 11. The recommendations say that it doesn't have to be fasting for that first one. However, if your non-fasting is abnormal, the follow-up is fasting. So do with that however you want as a provider. The other time you will get this is at the age of 17 to 21. So most of the time, they are with you now. The Army has said, go be with you, Val, and so they are with you. So that would be another of those AAP recommendations for you to get. Unless there are some of those risk factors, so if you have parents with significantly elevated cholesterol, more than 240, or they're significantly premature with coronary artery disease in one of the parents, meaning under the age of 40, that would be an indication to screen at the age of 2. Okay? How's my time? A couple more minutes. So let's check on this, and then right after this, then we'll take a 10-minute break. So a 4-month-old infant comes in for a well check, and you notice that the child is rolling unassisted. Are you concerned? We're concerned for rolling at 4 months. When do we roll? Rolling is at 4. Were we concerned? No. That's exactly what we should be doing. 15-month-old comes in for a well check, and during the exam, you notice that the child is not walking independently. Are you concerned? Yes. When should you be walking? 12 months. Yep. 6-month-old infant comes in for a well check, and during the exam, you notice that the child is unable to say any words. Are you concerned? No. When should they be saying words? What's at 9 months? Mama, Dada. When are some other words in addition to Mama, Dada? 12 months. How many are at 12 months? 1 to 2. Yep. Good job. Okay, before we jump into immunizations, let's take 10, and then we'll come back at 3. As a reminder, as we jump into immunizations, I do not want you to memorize the immunization chart, but there are going to be specific things with different immunizations. I'll try to pull that out for you guys. So as a reminder, terminology, again, just to make sure we're all talking about the same thing. There's a difference between active immunization versus passive. So active immunization, we are trying to get their bodies to make antibodies. So we're giving them either the toxin or the toxoid, I guess, or an antigen so that their bodies make the antibodies, versus passive immunization where we are giving them the antibodies. So you can get that from mom. There's certain other medications where we are giving them the antibodies themselves. Primary and then secondary. So primary is before any kind of occurrence. Secondary is going to be after that first exposure. So just so we're all on the same terminology. When you pull up, I know you guys have all diligently read your syllabi. And so if you click on the link for the CDC immunization charts, it will take you to this. I have no idea, I have a little idea, but this changes every year, right? So again, do not memorize this, but this is what your clinics, what you should have and be aware of every year, of this is the current vaccination schedule, right? So it should tell you at what age is dose 1, 2, 3, 5, whatever doses it is, and then what you are doing with that. Notice at the top, this is 0 to 18. There is very similar charts for 18 and above, so on your adult side of the house. And not to fear, let's say they come in and they had said, I don't want any vaccines, and now I'm 4 and I want to go to school, or we want to put them in school, so now we need all of our vaccines. What do? not to worry, there are catch-up schedules. So on there as well, again, please do not memorize this, but if you need a catch-up schedule, how often and how many do I need to do on that schedule is all there for you. What's the time between them? All of those good things about your catch-up schedule. What about special populations? But this child has asthma. This child has congenital heart disease. This child has sickle cell, just to pick a few. There are also additional charts of that to say who gets extra vaccines, more or less, different timings, what's contraindicated for what various different things. So things to be aware of. Actually, I should probably add that sometime. But congenital heart is one, sickle cell is one, asthma is one, any kind of immunodeficiencies are one. So things to be aware of. If it makes you stop as a provider and think, can this kid have those immunizations? They're probably on the chart. So just to be kind of familiar with those. And a PSA break. One of the things that will happen is there are different formulations. There are brand names, there are generic names. There's ones that are combination vaccines, meaning that we've put multiple antigens into one poke. So each base you go to might be slightly different, or each post or camp or boat or any of the things will be slightly different in how they order them. Okay, so once you get there, be familiar with what your clinic has available. So that, because a lot of times, especially in pediatrics, the parents, the number one question will be, how many pokes are they getting today? So that is different than how many diseases are they going to be protected from. Just okay. Another one thing before we start getting into the specifics. So if you have a preterm infant, we treat them like the chronological age. So this is different from some of the other things that we talked about as far as screening goes. We treat them as though that is the age. So even if they were born significantly early, they get their 2-month shots once they are 2 months out of the womb. Your only exception is that they need to be above 2 kilograms or 2,000 grams to get that first hepatitis B. That first hepatitis B was that only vaccine we gave at birth. Do you remember what the other poke was for those thighs? Vitamin K. Correct. So they got Hep B, vitamin K. If they're not over 2 grams or 2 kilograms, do they still get vitamin K?
Yes.
Yes. Do they then get Hep B?
No.
No. Correct. So these are ones what I don't need you to do. I do not need you to learn when they get specific intervals, right? So please do not go through and memorize hepatitis B has 3 doses. They are given at 1 to 2 months, 6 to 18 months. I don't need you to remember those things. I need you to pick out that is the one given at birth. That is the one that they need to be over 2 kilograms for. There's multiple doses they'll get at other times, okay? DTaP, as a reminder, this is diphtheria, tetanus, and pertussis. It's different than when you get older and you get the Tdap. You're like, wait a second, thought those were the same. Which one has more diphtheria? DTaP. Which one has more tetanus? Tdap, yes. So what are you more likely to have issues with later on in life? Tetanus. Which one, because your B cells don't work as well, are you more prone to as a child? Diphtheria. Correct. Your Haemophilus influenza is going to be another 3-dose one. Again, for epiglottitis and meningitis. That's why I, as a provider, never seen epiglottitis, despite having every single class you've probably taken here talking about epiglottitis. Hopefully it's because you never see it. IPV is inactivated polio. You might see things if you go look at your vaccination record, your own, if you were born, I think, before 1989 or 90, there will be OPV. So we used to give the oral polio vaccination, except it was a live vaccine, and that live vaccine started giving people polio. So we now use inactivated, the IPV. Okay, so fun tidbit to go look at yours. MMR, the first thing to know about this, it's not even on there, I should add that. It is your first live vaccine. So your very first live vaccine is going to be at 12 months. So before then, no live vaccines. Your meningococcal series, there's a whole bunch of different types of those. This is one particularly that changes base to base because there's all kinds of them. 2-dose series that you get starting as a teenager. This one, your boards love this question, and they specifically will ask a new military recruit or the college dorms. If you see college dorms or military barracks in a question, they're probably looking at something to do with meningitis, meningococcal, something to do with that. Hep A is going to be a 2-dose series. Your influenza, the thing to know about this one starts really early. It's off schedule from everything else. It starts at 6 months. And the only reason why that's specific is that the very first year that you give a child your flu shot, they get 2, 1 month apart. That's weird. That's different, right? So that's something different to know. Pneumococcal, we are giving those ones at your 4-dose series. Varicella, people used to think, why do we give chickenpox? I had chickenpox, you should have chickenpox. Until you see the secondary pneumonias, encephalitis, cellulitis infections that come with those, then you want all the kids to have varicella too. HPV, for both cervical and genital warts, as well as different types of cervical cancers, penile cancers, and anal cancers. Additionally, you can have prevents in any kind of throat, papillomas. So I had a child pass away in residency from transmission during birth and had recurrent laryngeal papillomatosis and eventually passed away. So this one's one near and dear to my heart that people should get. Well, something to know about this. You can, if you are before the age of 15, it is a 2-dose series. After the age of 15, it is a 3-dose series. So if you are under the age of 45 in this room and haven't had it as well, you are still eligible to get it as well. So kind of an interesting tidbit. And then rotavirus. This is your only oral vaccine that we still give. Remember, we don't give OPV anymore. Rotavirus is now oral. Oral and given under 12 months old. And another interesting tidbit, you cannot start it any later than 8 months old. So that if you notice, this is not on the catch-up schedule at all, because if you are over the age of 8 months, you've missed the window. Because you've missed the window for when rotavirus will cause life-threatening dysentery. Okay? So that is why. Few contraindications. So if you have had anaphylaxis, true anaphylaxis to one of these in the series, don't push it and do it again. That would be a contraindication. If you are in some sort of immunocompromised state where immunology has said no live vaccines or nothing that you can't get like that, that would be another indication for that. So pregnancy is considered that. So no live vaccines in pregnancy. That's why we don't give MMR during pregnancy. It's a live one. But these are some of your precautions. And so the precautions are where you are going to have to take your provider brain. Remember we talked about provider brain? We need you to use that for some of these instances, right? If you have a local or a little, a erythematous rash, maybe a bump, a small bruise, is that an indication that we shouldn't give vaccines? No, that's great. I always tell parents, that's fantastic. Now I know your child has a functioning immune system because I know for sure it is creating a response and a reaction, right? So that's perfect, that's great. Do we have a fever after vaccination? Again, same indication that their immune system is responding appropriately with all of the cytokines. That's fantastic. If you've had a recent exposure to something, again, not a reason to not give a vaccine. Breastfeeding is not a reason. Things to think about are if you're getting allergens, if you're getting allergy shots, are you having problems with those? How high are those? Maybe we don't do it on the same day, and we adjust a little bit. That's not a contraindication. Prematurity. Well, maybe, last time the baby didn't handle that super well and didn't feed very well for the next couple of days. Well, maybe let's back off a little bit or extend the time, right? You're using your provider brain. If you have penicillin or any kind of other medication allergies, it's not a contraindication. And then one that your boards will love to try to trick you on because it changed. We used to say if you had an egg allergy, a true egg allergy, you could not have the flu shot. That is not the case anymore. So now your only indication with a true egg allergy is your yellow fever vaccination. Okay, so flu shot, okay. Yellow fever is still a contraindication. We talked about the catch-up one, so please don't start over. You don't need to. If you're talking to families, there's still some vaccine hesitancy, especially after things and many of the changes that have come up with some of the schedules. So looking at the data, I'm happy to go through that with any of you guys so you're prepared for those conversations. But the risk versus benefits still prefers vaccinations as a whole because of pediatric deaths that will still occur worldwide from these various pathogens. Thing to know, this is just provider to provider. Schools will mandate this, and they will mandate it down to the day. So if you are thinking to yourself, that doesn't make any physiologic sense, you are correct, right? So if you said, this child is 3 years and 364 days old, seems like that's great, they're already here for their well visit, those parents were proactive, we should give those vaccines 1 day early. I would caution you, because I have had schools that will not let them come to school and will make you give them again, because they're early by 1 day, early by 2 weeks. So you could take on the school systems I will back you up, or wait till they're that age, just because the schools will mandate that. And then VAERS. Have you guys heard of VAERS before? What does it stand for? Yep, Vaccine Adverse Event Reporting. So if something happens, this is looking for collective data. So if you have a patient that was like, man, I got that vaccine and my thumb turned purple, and you're like, that's not what happened. Tell them to put it in VAERS, right? Because it's looking for collective trends and monitoring. It's not looking for necessarily the specifics. So if you start seeing, yeah, I did have some chest discomfort, I passed out after that vaccine. You're trying to coagulate all of that together. Okay? And then again, the schedule is updated yearly, so being aware of what the updated schedule is as the provider to be important. Okay, I know you guys are trying to hang tight, you guys are doing great. One of the things, we have a few more charts. I apologize, we're going to get through the charts together, we can do it. So one of the things for well visits is that anticipatory guidance. What are we going to help parents, family, friends, other providers be aware of for a developing child to prevent risk? So all of this is risk mitigation so they don't show up in the ER, in ortho, in surgery with something else going on. Okay? So let's take you, please, I'm going to highlight the things that I really need you guys to know, okay? So birth to 3, those first few days when you see them. This is going to sound weird, but I need you to know it, that the hot water heater should be set at 120 degrees or less. One of my questions on my board exam was, at what temperature should the hot water heater be set for children? And then just straight first order questions, straight memorization. So maybe it's just some trauma from that, but you guys aren't going to miss that. It's 120 degrees Fahrenheit, okay? But that is why, and you're thinking, why are you doing that at the birth visit? Like, really? Like, congratulations on your baby. Have you set your hot water heater? Like, that seems a little weird. It's not weird because I guarantee you, once the sleep deprivation and everything else sets in, they won't remember that, and now you have an 18-month-old who jacks the water all the way over, and now you have a scald situation. Now you have a bird or some other situation that is way worse than, hey, let's have the family set that right now. Okay? So 120 degrees, do not miss that. If you notice in the sleep, all of the ones up through 4 months, they're all going to be on their back. We'll talk about that in a little bit. For violence prevention, you're going to be just noting that for those families. And then the other one I really want you to look at is that 2-week visit, really talking to moms and being proactive about postpartum. So do you have some baby blues going on, postpartum depression? Oh, is there concern for pregnancy psychosis? Where along that scale are we? How well is a child going to be cared for if the primary or secondary caregiver is very, very unhealthy? So those are the ones that I really need you to know at those ages. So why are we doing the back to sleep? We said we were going to talk about that. Well, that brings us to a discussion on SIDS. So SIDS stands for Sudden Infant Death Syndrome. And this is defined as a child that dies under a year with no known cause. So if you have a child, so watch for this on your pants or in any of my tests. If you have a child that says they died of smoke inhalation, don't pick SIDS, right? Because it's not unexplained, right? If they died from carbon monoxide poisoning, well, it's not SIDS then, because it must be unexplained after a full investigation, both mentally and from a law enforcement standpoint. Okay, so this is a diagnosis of exclusion, and they also have to be under a year. So that's the other diagnostic key there. Things that will help SIDS. This is usually a question. So back to sleep, they're going to be on their back. You want them on some sort of flat surface, not inclined. Interesting, Sweden did a really cool experiment. They literally gave families like boxes, like cardboard boxes. And they were like, have your baby sleep in this box. Like, put your baby in a box. And their rate of SIDS went way down. So it was just a flat, non-inclined, separate surface. They did great. So, baby in a box. Same room, but not same surface. So again, you're worried about, is there something where the baby could get a head positioning where they can't get out of that? Did they get rolled on? Did they have pillows or anything stuffed on them? Some of the saddest situations are in a pediatric ER where a family has fallen asleep, rolled onto the child, and accidentally suffocated the child. Right? It's rare. When you see it, though, as a provider, you never want to see it again. So this is why pediatricians will stomp their feet and jump up and down for these things. So no loose bedding, no smoke or nicotine. I don't really know what the benefits of smoking and nicotine are ever going to be, so it's kind of like sepsis. You want to throw that one out there? Tummy time is going to help. That's going to help with the muscles of the chest and the head to make sure that they could get themselves out of any kind of positioning where they cannot breathe. One of the most interesting ones is offering a pacifier whenever they are going to sleep. Even if the pacifier fell out, there was a statistical significant difference from offering a pacifier and those children and the rates of SIDS. So offering a pacifier and having them start out sleep with that significantly reduced it. Avoiding overheating, so want to keep the room cool. Again, we're in San Antonio, unless it's today. We don't need to have rooms be 100 degrees for these kids. The recommendation is no cardiopulmonary or cardiorespiratory monitors at home. So there was a craze for a while, probably still going, where everyone had the Owlet. They were using all kinds of monitors on their kids that created increased parental anxiety with no helpful data or decreased rate of SIDS. So. And then prenatal care, postnatal care, vaccination, and avoiding any illicit substances. So be aware of specifically the ones that are highlighted, but so the rest of them kind of make sense. But what's going to be some of the downfalls of that? So now that we put every baby on their back, now that they don't have their heads fused together, now we have a situation where we've created the increase in secondary plagiocephaly. So plagiocephaly is a little bit different than what we had talked about in that first lecture. So craniosynostosis, where you had early fusing, the sutures fused too early, the brain could not grow. In plagiocephaly, these kids, the brain is growing, it's just funky looking, right? So there's flattening on that posterior surface on usually one side or the other, so their overall head circumference is still appropriate, but when you look at them on physical exam, things are a little wonky. So when you're looking above them, you're looking at the ears. Is there an ear that is anteriorly rotated? So that's one of the things you're going to look at. Most of the time it is from a torticollis, where they have a preferred side, and then they have shortening of that sternocleidomastoid on that one side. So PT and OT can help with those stretching and strengthening of that. And usually it will resolve without any intervention other than your PT-OT. There are a few that will be so significant that they will warrant an evaluation for some sort of shaping helmet. I would warn you, providers, about some of the helmets. I've seen more superficial skin and fungal infections than I have help from the actual helmet themselves, as long as your sutures are open and they're continuing in their therapies. The other thing, just if you are going to be practicing an active duty, TRICARE does not pay for a helmet, so it is not a covered benefit. So just don't spin your wheels trying to get it covered. It is not a covered benefit by TRICARE. So that one's free for you. As in free advice, not free. It's free. Okay, so that was the sleep stuff. Your seats, your car seat, the recommendations changed and now they're a lot more loosey-goosey. They used to say we need to have a rear-facing car seat until the age of 2. Now they've expanded it to say rear-facing as long as possible within the manufacturer's guidance of whatever car seat you have bought. You do turn them around by the age of 4 and you keep them in some sort of booster and in the back seat. Then booster until the age of 8, back seat until the age of 13. So for the risk of skeletal maturity. And having secondary injuries to that. If you think in this room, if you're like, did you ever sit in the front seat before you were 13? I'm like, oh. So, but that is the recommendation. It's like we're all medical marvels then in this room. We all survived the front seat. But those are the official AAP recommendations. If you want those same car seats and guidelines, again, if you like that chart in that way, it says the same thing. Your tobacco smoke, again, we want to avoid that as much as possible. And when people are asking why should I actually quit? Well, from that first lecture, your child is more likely to be small for their gestational age. It constricts the vessels and no flow, no grow, more likely to have a small child. It increases the risk of SIDS. It increases respiratory illnesses, particularly in that first year. Increases the amount of ear infections, increases the amount of asthma. So really, there's really no benefit and only harm for the child. Even in cases where they're smoking outside, using a smoking jacket, any of those things. So it is a recommendation for complete absence of any of that. We're moving on to the older children now. We've got into the 9 to 18 months. The concept of this whole chart is basically where they are mobile, but their language is very limited, right? So you have somebody that can move themselves from point A to point B, but they cannot either receptive or expressive deal with the language. So that is where risks for falls, hot things, falling off, doing all kinds of stuff is where the majority of your risk counseling is going to be. That is actually most of it. Always with the firearms, but that's the biggest part that I want you guys to take away, is the language, gross motor mismatch for that age. And people will start asking about dental at this age. I will say there's not a whole lot that PCMs do with dental. Most of the time we will say, go see your dentist, because there's a whole specialty. There are pediatric dentists specifically that I guess are glutton for punishments and just want to be bit all the time. That is why they do that, I don't know. But one of the things to say is that most of the time, teething happens around the same time they are ready to start solid foods. So roughly, so 4 to 6 months, you would expect a tooth to start erupting. Most of the time, there are those front, middle teeth. The delay in that would be if you had no teeth by 15 months. So if you're ready for solid foods and you don't have any teeth, just gum away. Gum away, my friends. I have seen kids gum all kinds of things. But really 15 months is your mark of, I think that something may be abnormal. And guess what it could be? Hypothyroidism is the most common cause. So your typical things are the things that you should think about there. Your permanent teeth, usually about 5 to 6, so kindergarten, maybe late kindergarten is about when you would start to lose your teeth and get your adult teeth. Wisdom teeth, again, will probably be what y'all are dealing with in young enlisted. The reason to know this specifically, you're like, why am I just telling you facts? Well, if you have somebody who is under the age of 6 who is missing teeth and they don't have a great story, oh yeah, we were at T-ball and got hit in the face, they just started losing their teeth early, that should prompt you to ask more questions. Is there abuse going on? Are they getting hit? Is there some sort of medical indication? Because they shouldn't be losing teeth at the age of 3 or 4. Okay? Make sure it makes sense. The families are able to give you reasons why. Because 6 is about the youngest you should see. So what should they be doing? So they need a dental home. This is a recommendation by the age of 1. This is another one I was like, my God, I don't even know how old I was when I went to the dentist. So I rode in the front seat and I didn't go to the dentist till I was 4. I'm a marvel, right? So those are some of the things that you can see. You're trying to avoid dental caries is the point to prevent that. So early on, you're trying to clean their gum with just a wet washcloth. Beyond that, you're trying to make sure that you get off the bottle as soon as possible. If you have a longer nipple versus a shorter cup spout, more likely that there's going to be glucose that sits on the back of the teeth, more likely to have dental caries. So if you really can't get them to give up the bottle, then at least add water and have water be what's in the bottle. Fluoride, these changed a little bit ago too. It used to have different ages where you could and could not have different fluoride. Now everybody can have fluoride, but it's just a very small amount. So the first side, a smear, they say, is the size of a rice grain, which if you can get a rice grain size of fluoride toothpaste on your toothbrush, like that's incredible. So just a small amount of that on their 2P size, I guess they were very hungry, and then a regular size after the age of 3. This is what can happen if you don't switch their bottle or take away the bottle or have water in the bottle, something to that effect. You start seeing the baby bottle. Your little bit older kids, let me find that chart, what I want to pull out specifically for you guys. For this age, with this, the biggest thing that you want to start talking about is healthy snacks. So this is when you will start having little terrorists in your home that will only want to eat chicken nuggets, gummy bears, and like Hot Pockets, or whatever. They will want highly processed carb-only food. So incorporating and making sure that families are aware of how to keep a balanced diet and nutrition going is going to be very, very helpful. We already talked about some of the booster seats there, and then just the increasing responsibility. So nothing specific that I need you guys to take away from that one. Mostly food choices, we talked about some of that. Discipline, you'll get asked about this some of the time. So the point of discipline, yes, there can be some as punishment, but it's mostly to teach. So you might hear this often if you have people that have only had animals, and they're used to saying bad dog or something. Really working to change the language to say that you have good kids that do bad things to make sure that you are not disciplining too harsh, but setting proper limits. The AAP does not endorse corporal punishment, so as providers, that is what the AAP's recommendation is. It should be limit setting and to make sure that the behavior is followed up with appropriate interventions at that point. So you don't want to have empty threats, you don't want them to be afraid, but there should be some sort of consistent boundary. So boundaries, firm on limits, should be with their age. So the biggest takeaway is that for things like timeout, they should correspond to the age of the child. So if they are 1, they should only be in timeout for about 1 minute. They are 4 minutes. And they should be in conjunction with whatever the event is. So if you have a 2-year-old it's been an hour since the event and you want them to sit and think about what they did, that is not going to happen. They do not have the abstract thinking to be able to do that. So you can right after the event, no more than about 2 minutes is the big takeaway for that. Extinction, one of those methods is to try to eliminate the behavior where you are functionally just ignoring it. So if they are doing something safe but annoying, the extinction method is functionally ignoring it versus the timeout method, which is having them be in a separate place for the age-appropriate time to cool off. When you're doing that. These older kids, so your school-age children, what you're starting to talk about at this age really is their peer-to-peer interactions. So what are they doing? What are they starting to make their own food choices, their own choice in what they are going to do with their time, with their homework, with all kinds of things like that. So mostly this is going to do with peers. And then 14 to 17, those teenagers, I always put food, safety, and sex. So they're making their own decisions with what they're going to do with their time, what they're going to eat, where they're going to drive, what their friends are going to do, what them and any romantic partners are going to do. So food, safety, and sex goes a long way with those. And we will get into those specifically with adolescents in a specific follow-on lecture. So, a quick check on learning. What gross motor skill occurs usually between 3 and 4 months of age? Yep, they should have the head, and then what else? Rolling, and then what should the shoulders be doing? Yep, pushing up. So baby yoga. What do they need at 9 months, gross motor? They should absolutely be sitting, crawling. Yep, some sort of crawling or pulling to stand, moving their whole body. What is the age that a child needs to be in a car seat for? Yeah, so rear facing. I'll ask it this way. Rear facing. Up to 4. So as long as your manufacturer is, ideally the old recommendation said over 2. So 2 to 4 is usually what we will tell people. Booster seat until 8. And then when can you be in the front seat? 13. Congratulations, you've all made it. What is the recommended sleeping environment for under 4 months old? Yeah, back to sleep in socks. And then what should the temperature be? Cool, should be comfortable for an adult. What should you offer them? Pacifier. Should they co-sleep? And specifically, so same room, not same surface. What about bedding, sheets, bumpers? Yep, none of that. What an incline, you already said flat. Okay. And then lead screening. When do you get the draw? When do you start the questions? Up until the age of 6 years. What are the other draw that you get at 1 year? Your anemia check. Yep. When do you get the lipid panel? 9 to 11 and 17 to 21. Is it fasting or non-fasting?
Unless they're obese.
Yeah. Unless you know that your follow-up, you're going to have to look again. Yes. Tuberculosis. Is it just questionnaires? Yep. What ages does the AAP recommend ASQ screening? 9, 18, and 24 months. What else happens at 18 to 24 months? Autism screen. What is that screen? 20 questions called the MCHAT-R. Yep. Modified checklist. Great. Questions, comments, concerns, frustrations, anxieties, grief, miscellaneous toxicities. Cool. Thanks guys. I'll hang around if you need anything. Otherwise, you're good for the day. We did it.